So we're really pleased today to be joined by several experts. Quat Thi Hai Wan, Executive Director of the Center for Support Community Development Initiatives in Vietnam. Javier Wacarde Belloc, Global Fund Board Member, Advisor Group Member of the Civil Society Engagement Mechanism and Civil Society Steering Committee Representative for UHC 2030. Beth Tritter, Pillar Lead for Policy Engagement Coordination and Communication, COVID Task Force at USAID, and Anushka Kayanpur, CARES Lead for Sexual and Reproductive Health in Emergencies. Welcome, everyone. Thank you so much for taking the time to discuss this important topic. And I'm gonna dive right in with questions for each of you. And we look forward to a really robust discussion. I hope you were able to join to hear Eliana's opening remarks on some of the highlights from the COVID paper. I know some of you were involved in this from the beginning, which we really appreciate. Juan, I'm going to start with you. Dumi talked a lot about the country context that they are in, and we'd love to talk a little bit about Vietnam. Vietnam's been actually really successful so far in keeping COVID cases low, although I know there's been a recent spike. But you've also achieved very high vaccination rates, I think 98% of the adult population, which is quite astounding. Can you talk a little bit about how communities have been incorporated into these efforts, and what are some of the lessons learned for marginalized populations? And what would you recommend happen the same or differently for future pandemics?
Thank you, Elisa. And I think I have a couple of picture to share with you.
Yes, we can.
Yeah.
Yep, there we go.
Yeah. Thank you. So just this, Alicia, you just mentioned that Vietnam have a very high vaccine coverage, and that is the number that I got today from the government report. You can see that it is by provinces. The green bar is the number of the vaccine coverage for the adult population, and then the blue one is for the 12 to 17. So you can see everywhere 100%, 99.8%. So on average, we have a very, very, very high vaccine coverage, and I can be a witness that is really high. It's not over-reporting. Because we work with the homeless people, we work with the undocumented people. Almost everyone, if not everyone, I haven't seen one who are left behind for the vaccination, for the COVID vaccination in the country. And I do meet a lot of people who are left behind on many other things. So this is just to say that this number show us many things. The first thing is that when there's a political commitment, things can happen. If you have a strong unified political commitment in among the leader of our country, nobody argue about the efficacy of vaccine. Nobody's argue about how important COVID vaccine is. And then vaccine diplomacy become a priority for the government. The president, the prime minister, the minister, everyone go and look for vaccine to bring COVID vaccine to the country. So it happened. The second thing that we can see from here is the global solidarity. Vietnam doesn't produce any dose of vaccine. We try to have our our Vietnamese vaccine. We haven't been successful. But all the vaccine that we got in the country come from abroad. Many of those are donated by different governments, including the U.S. government. And thank you. Many other governments have donated vaccine to Vietnam, and that helped us to have this high coverage of vaccine. And the third thing is that we have a strong health system. We have invested in public health system that consider immunization as one of of the primary healthcare services that all kid was born that get immunization. So immunization is become a culture. So we don't have those anti-vaxxer movement in the country. So I mean, there are a couple of them who are reluctant, but in general, we don't have that problem. So with this successful vaccination campaign, when the COVID hit us really hard, just a couple of weeks ago, about in my office, about 80% of our people have got COVID, over 80%. In the country, I mean, the reported number is over 10%, but the real number can be a couple more high like that. Would say 40, 50% of the population have got COVID, but we don't have a lot of that now. It's we can keep our lives as normal because of the high vaccine coverage, and it works because of all the things that I have mentioned and more. But we pay very high price because of COVID, and we can see that without the community, thing would have been a lot tougher for a lot of people. Can I have the next picture, please? Next slide, please. The Yeah. So this is what happened in Ho Chi Minh City during the lockdown, when the before we got vaccine. You can see that if anybody had been to Hanoi or Ho Chi Minh City or in Vietnam, you see street full of cars, full of motorbike, full of people. That is what happened during the lockdown. It's really a hard lockdown. It locked down. You can't leave your neighborhood. You was not allowed to leave your home. It's locked with whatever that prevent people to leave where they are. So you can imagine there's a people, especially the poor people who don't have much in stock, who cannot order for delivery. They don't have food. They don't have women don't have sanitary napkin, and then people with chronic condition cannot get the treatment. People living with HIV, people with TB, and other people, treatment and interruption is very common, and it was like 3 months of lockdown, if not 1 week or 2 weeks. So in that context, community system show they're important. So one way or another, we found way to be able to bring the medication, to bring food, to bring sanitary napkin, the diaper to the woman, to the children, to the family, and it's without the community system, a strong community system, it would have been some people would not have food to eat, some people would have to be treatment would be interrupted. It happened to a lot of people. We couldn't cover everyone, but anyway, with the community, we are able to support quite a number of people. Next slide, please. Okay, so that is but we have a very high cost to pay with all the resources is put in COVID. So when you ask what we can do differently, I would say we strengthen the community system. So the system is there to support people in the very place where they are, in the very situation that they found themselves in, where for the things that they need. But at the same time, we need to have a strong system to make sure that while we respond to the pandemic, other services are not neglected, and we don't have to pay the price we don't have to choose between one health issue or another health issue. There is a patient with TB that I visited in Central Highland. In this province, in this region, about 80% of the TB case was missed in 2021. So every 5 TB case, they could only diagnose one, could only find one. So you can imagine after the COVID pandemic, we will probably see a surge of TB pandemic. And because the people, the TB hospital was used as a converted into COVID hospital, TB staff was mobilized to respond to COVID. So leaving TB patient or people who suspect of TB have nowhere to go, or the hospital under quarantine, or the people under quarantine, or in order to get to the hospital or health facility, you need to do a COVID test and you need to pay for it, or you have to wait for a very long time. Public transportation is stopped. People couldn't travel, etc. So yeah, the second thing is that we need a strong systems for health that include the government public health system and community system, so that we can while we are responding to the pandemic, we can still respond to the other needs, in particular the essential needs of the people of the community. So I think I stop here and be happy to discuss further and answer any question. Thank
Thank
you
you.
very much.
Thanks, Juan. Yeah, it's a really, I mean, it's a really interesting point that you raise about the push on COVID has also cost us a lot on essential health services, and that we need a system that can do it all, and that we can't divert our attention from existing disease burden and other services that people need, and really making that community and health system work together is really important. I'm going to turn to Javier next, because I actually think this is a good segue for you, since you've worked quite a bit of your career, spent it working on HIV. And, you know, it sounds, when we hear from Dumi, Eliana, from Juan, there's a lot of deja vu almost, of things that we've faced in the past with other pandemics. So I'm wondering if you can talk a little bit about what we should do differently to ensure more equitable response, and from your place from UHC 2030, a little bit about universal health coverage as a part of that solution. And you're also a Global Fund board member, so would also love to hear what multilateral agencies can do in addressing the needs of marginalized populations and communities.
Okay, thank you. Thank you very much for inviting me to this event. Although it's too early to learn lessons about COVID-19, perhaps my first reflection that struck me in the middle of the first year of the pandemic is that even though we have been repeating like a mantra the importance of resilient health system, neither in the so-called South nor in the so-called North, there was such a thing like a resilient health systems. Apologize if I repeat some of the issues and recommendations that Eliana, Dumi, and Juan just clearly outlined before me. Something we have been learning from HIV, COVID remind us, is that focusing only on health and well-being, SDG 3, only just is the tip of the iceberg. So what happened between SDGs and the COVID pandemic? Between a well thought set of agreed goals and targets, we need to be translated into the reality. COVID is rubbing the face the intimate relationship between health and poverty. Until we end it, SDG 1, access to health services will be a privilege. Our AIDS, LGBTIQ, and sex worker service organization, as one mentioned, over the last few years have had to literally feed out our communities, SDG 2, because with hunger, with an empty stomach, there is no scientific state of the art discovery that will vaccinate, treat, or cure. And some decision makers and part of the public opinion still believes that COVID is only a health emergency. Some even discover with COVID the link between social protection and health. Well, it's too late for that. Many of us have access to technological resources, and our children had access to education from our homes, attending online schools, classes on computers or tablets. SDG 4. Most people on the world at best have most expensive data plans on their phone alone, but in addition to not having Wi-Fi, they did not have access to clean water and soap. I believe that SDG 6. UNICEF published yesterday that in 23 countries, more than 400 million children and adolescents remain out of the school or formal education. The digital gap is a mortgage on education of most of children and young people, and a key priority to reduce inequality, I think relates to SDG 10. In most of our countries, an increase in domestic and institutional gender-based violence has been documented the last 2 years, and that means speak very eloquently about that. Many uniformed personnel felt unpunished during the quarantine with women, young women, and girls, including transgender people. Not anyone, but the most vulnerable women who are homeless, lost their homes, migrants, sex workers, or precarious street vendors, among others. And so gender equality, including protection of human rights, was taken away by risky emergency response. And this is probably related to SDG 5. Shops evaporated, and for 2 years we stopped growing, which resonated with SDG 8. Big cities proved to be unsustainable, and a virus super spread. I think it's related with 11 SDG. And the impact of the pandemic on our ecosystem is already being discussed, and it's might probably related to other two SDGs. I will stop listing Sustainable Development Goal for now. I wish to make the case that we have a rhetoric and we move into actions. We focus on health alone, it's short-sighted. Respiratory virus can wipe out the modest progress we made on the Sustainable Development Agenda. Without equity, equality, respect for rights, education, technology, and a strong present state, health is and will be forever an outcome of for the few. 40 years ago, we tried to respond to HIV/AIDS pandemic, and 2 years ago, COVID-19 did face us with a gigantic deja vu. Stigma and discrimination will kill more than viruses. Up to date, we do not have a clear picture of the number of people living with HIV or TB lost from the continuum of care. My second and last reflection, as Alicia asked me, is what should the global health institution must do during the pandemic? My personal experience has been with the Global Fund to fight AIDS, TB, and malaria. What was done as a public-private partnership was the immediate introduction of flexibilities in the resources already allocated and disbursed into the banks of implementing countries. Then C19RM was created, investing additional resources initially for fast emergency response and later for a full proposal format. By the end of the first year of the pandemic, billions were channeled to the response to COVID. Was neither easy nor straightforward. It was a ship that we built by sailing. But already we see the last round of the C19 and RM. We got countries to clearly link the investment mechanism with health system strengthening with HIV, TB, and malaria outcomes, as this is the Global Fund main mandate. We also ensure an effective and meaningful participation and monitoring of civil society and affected community, which is a Global Fund core value and central to our strategy. This requires a donor community to be willing to open the spectrum of their agenda and respond to a crisis in a timely manner. More resources are always needed, and when they do an effort, money is there because the response to COVID required additional funds on top of what was pledged for HIV, TB, and malaria. But even when many countries had resources to buy, there was not supply. Vaccines, for example, continue stockpiles in rich countries. Lack of access again, as in the 19 with AIDS pandemic and HIV treatment. There is still an obscene number of countries that have only been able to offer the first dose of COVID vaccines to between 30 to 50% of the population. Pandemics bring out our best and our worst in people. They confront us with health systems that may not be resilient, and what is even more serious, that they may not be sustainable. Something is in our actions, and our narrative on health must change. Otherwise, 2030 will find us trying to understand why it couldn't be. We are because you are. Thank you very much.
Thank you, Javier. There's a lot of really good information in there, and I think your point that it can't be just about health, and that is intersectoral is a key point that we came across over and over again in our community focus groups. And I think Juan also made that point, as did Dumi. And so now I'm going to turn to Anushka and actually ask her to talk about that a little bit. Anushka, you work with CARE. And just as we talked to a range of stakeholders for our COVID paper, who told us, as I said, that it's demographics, it's social, it's economic factors, everything that intersects with health, that goes into continued marginalization of communities or improved access for communities. I know that CARE as well focuses a lot on those intersections, and that you really strive to be local in your response. across the board. So can you talk a little bit about, from CARE's perspective, best practices to meaningfully engage local actors in program design and decision making, and particularly those who may be disenfranchised or marginalized?
Absolutely. I'm happy to do that. Thank you. So CARE takes a gender lens and an inclusive approach to all of our work, including when responding to emergencies. And, time and time again, we found that programs have both had the greatest buy-in and the greatest impact when they reflect community priorities, amplifying the voices of marginalized subgroups, and are locally led by those affected communities. This ensures that we aren't leaving anyone out of the response and that we can remain focused on what communities themselves say they need the most. For example, while the pandemic shifted our focus to COVID response, it was because of this meaningful participation of these communities that we were very early able to identify exactly what Juan said, that ensuring continuity of care for those essential services, such as family, important and actually a key aspect of our pandemic initiatives. So today I'll highlight two approaches that we take for meaningful participation. There are obviously many more, but one is utilizing the rapid gender analysis to inform our responses. And second is embedding accountability within all of our programs. So first, CARE has really pioneered rapid gender analyses. In the early days of a crisis, we conduct these RGAs in collaboration with women's rights organizations, community-based organizations, to get an understanding of the needs, capacities, and coping strategies of women, men, boys, and girls, and people of all genders, so that we can ensure that our responses and recommendations for program staff, policymakers, and other stakeholders are truly gender sensitive and inclusive. So we need to make sure that we're aware of and responding to communities' unique needs and also leveraging their capacities. The RGAs are designed to lift those voices quickly and often. So we really take an iterative approach to sharing those evolving perspectives of women's rights organizations and affected communities. So actually, within the first week of COVID-19 being declared a pandemic by the World Health Organization, I was involved in publishing the first ever global COVID-19 rapid gender analysis, which reportedly went on to influence the UN Global Humanitarian Response Plan for COVID-19, as well as the UN Secretary General's thinking for the UN's global response to the pandemic. About 74 CARE country offices have since completed their own rapid gender analyses, including the first ever US-focused RGA. We've summarized the key themes, including needs, capacities, and recommendations from the perspectives of these different groups in summary snapshot reports under the She Told Us So report that was released in September 2020, and the updated She Told Us So Again report released earlier this month. And, not surprisingly, these COVID-19 themed RGAs really highlight many of the same themes and recommendations that have been highlighted in the GHC paper we're discussing today, as well as what many of my co-panelists have mentioned already. A few ones that I would like to highlight, especially for health actors, are one, around ensuring the protection, dignity, and recognition of the role of frontline health workers, the majority of whom are women. Second, ensuring that women and other marginalized groups, especially leaders at the last mile from diverse subgroups, are at those decision-making tables for COVID-19 and for any other emergency preparedness, response, and recovery. And finally, supporting the continuum of care for essential health services, including sexual reproductive health and rights. So the second piece that I wanted to highlight, and during COVID-19, one example that really inspires me is when our colleagues in CARE Malawi partnered with youth leaders and existing community structures to quickly pivot from in-person remote use of our social accountability tool, the community scorecard, that really amplifies the voices, perspectives of different subgroups of communities in real time, which are then utilized to influence local policy and practice. In the early months of COVID, when access to other essential health services was severely hampered, and there was a ton of diversion of resources, as we know, the CSC community scorecard process resulted in data-informed advocacy, resulting in the government allocating additional funding to ensure that there was sufficient family planning supplies, even at those local health facilities. So in addition to ongoing accountability and input with our programs like Community Scorecard provides, we really aim to ensure an intersectional, inclusive, community-centered approach for meaningful participation and leadership in ongoing programming at the heart of our work. So, whether this is leveraging and supporting the leadership of local LGBTQIA CSOs in Venezuela, who work to help navigate the health system for refugees, or setting up adolescent leadership committees in places like crisis-affected Syria or Northeast Nigeria, so that adolescents themselves can be at those decision-making tables to share recommendations, to influence and make sure that programming is more responsive to their needs. So, I think in reflecting on all of this, it is more clear than ever that investing not only in the technical skills, but also the leadership, agency, and recognition of women, youth, and other marginalized subgroups at the last mile in stable situations has organically served as a core preparedness action to them playing a critical role in ensuring resilience of community-based health systems, even during crisis, and this was demonstrated by the pandemic. We're actually pulling together some learning on this, so hopefully you'll see some of these impact data in May through a report that we'll be sharing. But I think I would like to leave you all with one call to action, which is really investing in women and diverse populations' leadership skills and ensuring that they're at the decision-making table for more responsive health policy and practice. Thank you.
Thank you, Anushka. That's great. And we're always impressed with CARE's reach out into the community and really the participatory approach that you take. It's very refreshing and heartening to see. So thank you for that. I'm going to turn now to Beth Tritter, who's our USAID representative, to talk a little bit about the US response. And I think we all know that US has really been leading in the global COVID response. And I think earlier this month, hit a milestone of 500 million COVID-19 vaccines being delivered, donated free of charge to 110 countries, I believe. So that's a huge deal, a huge accomplishment, but we know it's really only the tip of the iceberg. And in terms of the need and in terms of the equity question. So Beth, I'm wondering if you can talk a little bit about USAID's efforts and particularly how you're engaging with communities and including communities and ensuring an equitable response as the US continues to push on global COVID response.
Excellent. Thanks so much, Elisha, and thanks to Eliana, the whole Global Health Council team, and also to Dumi, Juan, Javier, and Anushka for really setting the stage for a great conversation going forward. I'm thrilled that you're putting together this conference and think that these conversations are so important. As you said, the U.S. is indeed committed to bringing the same urgency to global COVID response that we've seen devoted to the domestic COVID response. And to date, we've invested billions of dollars in more than 120 countries to fight COVID and to address the social and economic effects of the pandemic. And U.S. vaccine donations, as you said, have helped to close the supply gap in low and middle income countries. But as we know from the domestic vaccination efforts, vaccine availability is only part of the process. And I think we've really seen over the last few months just an uptick in reports coming out of countries that are saying, okay, the vaccine availability used to be the problem. Now vaccines are available, but we sort of have a tarmac to arm problem now, which is how do we get those vaccines from where they're dropped off in country to where they actually reach people who need them, including people who generally have trouble accessing healthcare in the best of circumstances. And certainly with COVID-19, we've not been in the best of circumstances. So we're going to be focusing a lot, and we already are, and we will continue to be focusing a lot on the complex work of getting shots in arms, which is sort of an inelegant way of saying getting vaccines to people, which is really what this is about. So Global Vax, which many of you might be familiar with, is a US government effort to contribute to the global goal of vaccinating 70% of the population of every country against COVID-19 in 2022. And it's a whole of government approach that's building on the extraordinary commitment that President Biden has made for vaccine donation. And you mentioned the 500 million milestone that we reached last week or 2 weeks ago. And it really intensifies our efforts to get shots in arms, really working hand in hand with international actors like UNICEF, which hosts the sort of global coordination mechanism on vaccine delivery, but also working hand in hand, most importantly, with country governments and with communities in country, building on a lot of the platforms that the US government and countries and communities have built over the last 2 decades to deliver other pieces of the health puzzle. So I think that in an ideal world, providing vaccines to people is not only about sort of mass vaccination sites and big campaigns. It's also about reaching people where they are, making vaccines accessible in whatever way access means. And access means different things to different people. I think earlier this year, we heard a lot about hesitancy. And hesitancy and sort of the misinformation crisis is a big problem. But we've been really careful not to confuse hesitancy with a lack of access. Often people are hesitant because vaccines aren't being offered to them and aren't reaching them in a way that makes it easy or even available for them to access. And so if the barriers to entry are too high, so if you have to wait in line too long, if you have to travel too far, if you have to visit a place where you have not received respectful care in the past, or where you feel uncomfortable, those are all access issues that lead to hesitancy to become vaccinated. But I think those issues are separate than some of the hesitancy issues that we've seen due to mis and disinformation. And so it's really important for us to sort of make sure that we understand what those access barriers are, including for populations that have generally been marginalized, and for women who have other things that they need to go about their day to do, and other responsibilities, and for those who are most burdened in society right now. And as I said, what Global Vax is trying to do is to build on platforms that already exist, not to create things from whole cloth. We simply don't have the time to do it. And as I think many of the panelists have alluded to, building on the platform of the health system is the most sustainable way to accomplish something like vaccinating everybody for COVID around the world. And ideally, we come out of this period of vaccination where, over the next year or so, where health systems have been strengthened as a result of all of the resources and the efforts that we're putting into COVID vaccination. So as we undertake Global Vax, we're really trying to take on a country by country focus, not going in with sort of a set toolbox and saying, here's the way we're going to do this, really listening to countries, taking a look at their own vaccination plans, taking a look at what they're hearing from communities, and engaging with communities ourselves through the course of the health work that USAID and other US government agencies are doing every day. So that includes building on the PEPFAR platform, building on the President's Malaria Initiative, building on the huge network of partners at the community level that we have to work on maternal and child health, and actually figuring out how to integrate COVID vaccination into a lot of those platforms and with a lot of those same trusted partners that understand what their communities need and can advise on how best to reach people in a way that actually improves access, equitable access across the board. And just a couple of the ways that we're doing this. Well, I guess one thing I'll say is, we hear a lot about, obviously, the global goal of 70% of each population. What would be a shame is if what we tried to do is just reach that number for the sake of reaching that number. As we know, as vaccination rates go up, it becomes harder and harder to reach those last percentages of folks. And we're nowhere near that in particularly many African countries. But I do think that we need to be careful as we go for these very ambitious and rightfully so goals of vaccination to make sure that in addition to reaching people who are easy to reach, we're reaching people who are hard to reach. And so one of the goals of Global Vax is to try to see how we're making a specific effort to reach those communities that are harder to reach, not just sort of trying to tick up the numbers as quickly as possible for the sake of ticking up those numbers as quickly as possible. And then a couple of examples of what we've tried to do. So for instance, in India, USAID supported efforts to reach elderly populations that were really under-vaccinated by identifying where they were located, working with local organizations and opinion leaders to reach them, and facilitating registration and transportation for vaccines. And those over the age of 60 that received their second dose increased from 33% in August of 2021 to nearly 78% in January of 2022. In Colombia, we worked with indigenous governors and traditional doctors to reach indigenous populations that were more socially and politically isolated, and made a concerted effort to do that. And in Nigeria, USAID has been using existing community-based drug pickup points to reach people living with HIV with vaccinations. So, making it easier for folks who are already accessing other health services. And I think that one of one thing I would leave you with, which is also something that we're very conscious of and focused on as we move forward. There was a recent pulse survey that came out of the World Health Organization where they were polling sort of health leaders in different countries, and countries were self-reporting that COVID vaccination was actually one of the driving forces behind a suppression of routine immunization, and that there were enduring setbacks in supply and demand for routine and essential health services across the board in many, many countries. I think that really crystallizes for us the challenge here. That we all know that there have been setbacks since COVID hit, but as we're investing in COVID response and investing in vaccination, we need to be asking ourselves constantly, how can we do this in a way that's going to bolster these resilient health systems that, Javier said, as we've seen, they don't exist, right? There aren't a lot of resilient health systems out there that are built to withstand something like COVID. But how do we ensure, build back better seems quite cliche, but that is actually what we want to do. I think what we want to make sure is that when we're investing in COVID response, we're actually doing it in a way that's going to leave health systems better off than when they started, as opposed to depleting the sort of already tenuous resources that we have for dealing with other routine and essential health services that people need. We don't want to be prioritizing people's health for them. We want people to be able to prioritize what they need for themselves and to be able to assert that and be able to access that. And so our COVID response needs to be sensitive to that. Thanks.
Thank you. Thanks so much, Beth, for sharing all of that. I think the health system, resilient health system, has been the theme of this. And I think it's important for us to recognize that that's not just point of service, right? That's definitely meeting people where they are, but it's community health workers, it's diagnostics, treatments, technology, laboratories. And so that's essential as well for responding to COVID, but also really building that system. We have a number of questions coming in and comments, so I'm going to turn now to take some of these. There were a number of comments asking about response and engagement of migrant populations, internally displaced persons, people in conflict. We didn't really get to that in the COVID paper, unfortunately, although it was on our list of really important and key populations to reach out to. But I'm wondering if, and maybe I'm going to ask you, Anushka, because I know how much CARE does on humanitarian settings first, to just talk a little bit about how you engage local actors and communities with so much instability surrounding their daily lives. What does that look like?
Absolutely. Thank you so much. And, it's what's interesting from my perspective, since I even previously have mostly worked in emergencies, is that I think we've learned a lot from our regular emergency programming that we've now pivoted and adapted to for COVID, right? So, for example, the rapid gender analyses that I shared, that originally stemmed from what we we've now incorporated into in the COVID context. So, I think what we're seeing in terms of IDPs, migrant communities, refugees, they are obviously even more disproportionately impacted by what other populations are experiencing right now. I think, when it comes to vaccines, as Beth mentioned, it is getting the vaccines from tarmac to arm. And what we have identified is obviously with refugees, there are issues even in terms of registration, because vaccines in many contexts require national IDs. So in many contexts, UNHCR is sort of really helping to try to drive that forward to address those gaps. I think Javier mentioned, stigma and other issues that usually keep and xenophobia that might keep refugees away from the formal health system in general. This is now further exacerbated and then further hinders their access to COVID-19 vaccines. So I think it's really keeping all of those pieces in mind as we move forward to consider their unique needs. And as in the first the earlier part of the panel, when we talked about meaningful participation, I think it's really critical that we continue and enhance our approaches for meaningful participation in this COVID-19 context. And one practical example maybe to give you all is CARE has actually recently developed the first practical tool for frontline humanitarians to support women, women's rights organizations to take the lead in responding to crises that directly affect them and their communities in crisis settings. So this approach is called Women Lead in Emergencies. And actually the toolkit is available online. It's really an innovative 5-step approach to supporting women in crisis-affected contexts to create transformative change. It includes helping women to take the lead in emergency response and recovery first. Second, putting money and decisions in the hands of women directly affected by humanitarian crisis. And third, providing practical tools and guidance for frontline humanitarians. Just a few quick points to note in terms of like actions as examples. We heard in Colombia, for example, that these women decided to collaborate with the military to establish health brigades to really reach those last mile, hard to reach populations. In Uganda, we saw women's groups mediating with role model men in household disputes. In Niger, we saw a lot of the financial impact of COVID actually negotiated with the health system for reduced costs for skilled birth attendants, so that this actually drove and improved access to delivery by skilled birth attendants. So I think it is really ensuring that we keep this meaningful participation of crisis-affected communities, LGBTQ populations, really the hard-to-reach populations at the center of our work moving forward if we truly want to have a responsive impact. Thank you.
Thanks, Anushka. That's great. And we can certainly share the toolkit in follow-up materials if people are interested in seeing that. Does anyone else want to weigh in on this question around migrant populations before we move to the next question? Happy to open it up to others. Although Anushka said a lot, I think we can. Okay, so there was a question for you, Javier, which was, did you want to say something?
Yeah, I just about the migrant population.
Yeah.
We can, I think the migrant population are one who are most vulnerable during the pandemic, because of the restriction in travel, because of the access to services that in many cases are provided by local government to the local residents. So the migrants are the one really left behind. And I think if we really, as I can see that in my country during the COVID lockdown, if we have a strong community system, it is a community system, then can cross the boundary, can go beyond the bureaucracy and administrative procedure Do you have a residence registration? Do you have a paper, etc., to provide the support that is needed during the COVID? Because during the COVID, the migrants are really the most vulnerable in terms of housing, in terms of food, in terms of medical needs, etc. So again, I cannot stress enough the importance of having a strong community system. Having a strong health system is crucial. We all agree about that. But for the most vulnerable and in particularly the marginalized and the left behind population, we need a strong community system that there cross the border, the boundary, the bureaucracy to reach out to the people who are hardest to reach and the people who are left most behind. Yeah, and I can just say one thing is that among all the global health program that I have seen, it is the Global Fund for HIV, TB, malaria is probably the one who is most successful and most systematically invest in the community system. In my country, in Vietnam, it is because of the Global Fund investment that we have a strong community system that can reach out to all sort of people during the also during the very hard lockdown. The sex worker who had nothing to eat, who had to go out to find client, despite the risk of getting COVID. If there's no community system there to support her and her family, sure, she put herself and her family and the community at risk because they need to eat. As simple as that. So again, I would think there's a question about how to move from the theory to action, and that is that invest in community system. And if there's a one mechanism that I could see at the moment, it's the Global Fund for HIV, TB, malaria, and it is to invest in the Global Fund and then to advocate for the Global Fund to increase investment in the community system is the way that help us to have a strong foundation for not only pandemic but also the crisis that any crisis that happen, because community is always there. Thank you.
Thanks, Juan. Actually, this is a perfect lead to the question I was going to ask Javier, which is someone in the audience asked for you, how can we achieve reduced complexities and bureaucracies that small and grassroots organizations often find in trying to collaborate with multilaterals? And I think, Global Fund as an example, how can communities get involved?
Well, I think that depending where the resource is coming from and which is the mechanism. And sometimes each and let's say priority countries in the Africa region, they have 3 or 4 different bilateral and multilateral donors, each of them having different reporting mechanisms, application mechanism. So as pandemic response or humanitarian crisis, people need to get around the table and mainstream and simplify things. In the case of the Global Fund, we have a country coordinating mechanism. Of course, there is many dysfunctional country coordinating mechanism, but civil society, communities, key populations, and people living with the diseases have the same right, both rights than agencies or the government. And the Global Fund received concept notes developed and signed off by the country coordinating mechanism. Of course, that's not basically solve the issue of bureaucracy. Sometimes we see as a response to long-term sustainability or after the Global Fund, how the government could social contract civil society organizations. And believe me, all the attempts we have are highly bureaucratic in the country that access to money from the government. So this is a priority. The Global Fund has been the last 20 years of existence trying to mainstream processes and to become more responsive, but there is no room for avoiding meaningful engagement of civil society, communities, and people living with the diseases in decision making and in implementation, at least with Global Fund money. I quickly, Alicia, if you give me like 20 seconds, address the issue. Address the issue of vaccination. I was checking the World Track Vaccines page as I hear my colleagues, And the reality is, you can see 58 or 64% of coverage of vaccination. But this is the average. Let me list only 6 countries where, like Ukraine, 34% coverage of vaccine, South Africa, 30%, Nigeria, 4.6%, Angola, 18.2%, Kenya, 15%, Tanzania, 4.7% of full vaccination coverage. This is obscene. And we should not continue sharing average numbers, because of course my country where I live and where I was born have 86% of coverage. Congratulations, Argentina. No, this is not the case in the rest of the world. Thank you very much.
Thank you. I mean, it is obscene. I agree. I think that there was a question in the chat about how, and one started to tackle it a little, about how we turn theories into action. And I think one of the key recommendations for us in the COVID impacts paper is that representation matters, right? And not just, I mean, representation at the table matters, but representation in data matters as well. So to your point, Javier, the aggregate numbers are not making everyone visible, and we need to be better about disaggregating data. But I would love to hear from our panel your thoughts on this question of how do we turn theories into action? And as a lifelong advocate, this is my favorite question of like, what can we tangibly do to make a change? Who wants to kick off? Beth.
I'm sort of a lifelong advocate also, even though I work in the U.S. government now. So, I mean, picking up on what you were saying about data, I think demanding better data is one of the really concrete ways that advocates can actually turn these theories into action. Not just sort of working off of and advocating based on the data that you have, but demanding that data be better, and that it be more, that there be more disaggregation, that there be more detail, that there be, greater periodicity. I think that one of the things that we are encountering as we start working in the global vax surge countries, and at this point there are 11 of them, is that in some cases we want to be able to report on things that just aren't being collected by the government, and that is a key limiting factor in almost any type of health intervention. I used to work on primary healthcare, and we had a huge problem on primary healthcare data also, and data that was relevant to improving primary healthcare. It's really hard to be able to make specific recommendations to a government or to anybody with money about what they should do if you actually don't know what the results are of what they've done already. And so we are investing. That's one of the key areas where we're investing, depending on what countries need and are asking for, and what we're assessing is needed, is getting better data and making sure, as we were talking about just with refugee and disadvantaged populations, like being able to register, being able to figure out who got the first shot and finish that data entry, which sometimes takes months after the shot's actually given. And then at that point, you want to reach people with a second shot, but you need to know who they are and where they are in order to be able to do those campaigns. But the more that advocates say, we need to know this, why do we not know this? Why are you not investing in this? It becomes more of a priority for government, who then demand that donors are investing in that, and also demand that their own ministries of finance are investing in that. So I think it's all part of this beneficial cycle, and advocates can play a really strong role in making sure that happens.
Thank you, Beth. Does anyone else want to chime in on the theories to action? Juan?
Yeah, I just want to repeat what Beth said earlier. Beth said that we should not determine the priority of the health need for people, but should let people to identify what are the priority for them. So, also colleagues mentioned before that representation is important. So again, in order for people to be able to represent and to have voice, in particularly the voiceless people, the people who live in the margin and forgotten and locked up or neglected, we will really need them to be organized. We need a system that support them. So just again, I cannot repeat it enough. Community system, invest in that. That will make the theory in action. We will give the voice to the voiceless people, and they know what is important for them, and they can reach the hard to reach people, and they can participate and can step up to fill the gap when the health system having a challenging time. So invest in community system. Thank you.
Thank you, Juan. I think that's so important, that what you just said, that people know what's important to them and they can tell us. I think that if we just kept that in the front of our minds, global health would work much better. We're almost at time, but I did want to just ask one more question to the panelists, because as you know, tomorrow we have a working session, and many of the CSOs on this call are going to work in small groups, starting to develop advocacy plans using the Health for All advocacy toolkit, and based on some of the recommendations coming out of the COVID-19 paper. So in practical terms, do you have any advice for the groups tomorrow as they start on this journey of developing an advocacy strategy?
Really briefly,
Yes.
Make it as specific as possible. Make it as easy as possible for policymakers to do what you want them to do. And so be as, directive and tell them what you want and what you expect to get for what you want.
Thanks, Beth. Javier?
Very briefly, make your voice heard. Work as a reality check, because you work at the community level and you are part of the community systems. And as part of the community system, you are part of the health system, but also claim the decision-making power. One thing I love about the Global Fund is that communities, one sex worker or transgender person has the same decision-making power than the Ministry of Health in most of the CCM. So reclaim the right to make decisions, not only to voice our issues and concerns. Thank you.
Great. Juan or Anushka, any last words of advice?
Sure, happy to jump in. I think picking up from what's been discussed, to me, I think it's really about data-informed advocacy. So how can we use real-time data from women's rights organizations, CSOs working on LGBTQ issues, everything we've just said? How do we make the voices of the communities heard and turn that into data-informed advocacy? Thank you.
Great. Juan?
Yeah, I think data is very important, but data also a kind of evidence, and there's also equally powerful evidence. It is the voice of the people, of the real people who live the life in the community. So participation of the community members, of the local people, is also very important. Thank you.
Thank you all so much. I'm going to end us with these words of wisdom, which is, I think, first of all, claim the decision-making power. I think that is a real shift in how we are taught to think about it, that we should wait till the power is granted, but it is claiming it. That's a very key piece. And then really lifting up populations that have not been visible in data and in lived experience to inform our advocacy work, and being specific as possible. Beth is right about that. Claiming the decision-making power is also being able to tell people what they should do for you. So as we head into tomorrow, I think those are really astute words. And I just want to thank all of you so much for sharing your voice and your experience, and making this a really dynamic and interesting session. We appreciate the time that you took with us today, and we look forward to continuing to work with all of you.